Welcome everyone to this review of Psychiatric MCQs encountered in Family Medicine Examination in Saudi Commission for Health Specialties. I am Hamad Al-Ghamdi from Makkah Academy of Family Medicine. We are going through MCQs that related to psychiatry encountered in family medicine. These are some abbreviations that we are going to come across in the presentation. You can pause the video here and continue when you are familiar with it. So the first MCQ is 32-year-old female, known case of major depressive disorder on fluoxetine, followed up after 6 weeks for dose adjustment with no improvement and complaint of loss of libido. What is the management? So this patient, review of antidepressant after 6 weeks is the best time for evaluation of efficacy of the antidepressant, and the patient is not improving, so we have to either increase the dose or switch the medication or augment the medication with other medication, and complaining of loss of libido. So we have to use an antidepressant that will affect positively on sexual function of the patient. And among all the SSRIs or antidepressants, only bupropion, trazodone, and nifazodone are the antidepressants that will increase the libido or improve the sense of desire, of sexual desire. So the correct answer is add bupropion to the fluoxetine that he is already on it. Switch to TCA is incorrect answer because TCA has a higher side effect profile for sexual desire or sexual function. Add another SSRI. All SSRIs will affect negatively on the sexual function of the patient. Stop fluoxetine. So what we are doing here, the patient having depression and need treatment. Answer is A. The combination of bupropion and either an SSRI or NSRI is generally well tolerated, can boost antidepressant response, and can reduce SSRI or SNRI associated sexual side effects. In this table, we can see that all antidepressants have negative effect on sexual function that will decrease the libido and may cause also erectile dysfunction, or cause painful ejaculation or anorgasmia. But the only antidepressants that will increase libido are the bupropion, trazodone, nifazodone. Mirtazapine are a neutral antidepressant that will not affect positively or negatively on sexual function of the patient. What is worth to be mentioned here is that trazodone are the only antidepressants that will cause priapism as a side effect. This is a point of MCQs. And the other one is that antidepressants can cause painful ejaculation. Let's test our knowledge now. Patient, known case of depression on fluoxetine. He is doing well, but complaining of sexual dysfunction. What medication to switch this patient to? We have to switch, as the questions say. We have to stop fluoxetine to other antidepressant. Among all of those antidepressants, mirtazapine is the correct answer because it is the neutral one that will not affect the sexual function of the patient. But of course, if bupropion or trazodone are among the questions, are among the choices, we will choose bupropion or mirtazapine trazodone. Another question, 25-year-old female with SLE presented with depressive symptom of low mood, poor concentration, poor appetite, and sleep disturbance. What is the next step? Do we have to admit this patient, start medication, start cyclophosphamide, or ask about suicide ideation? So this patient is not diagnosed yet with the depression, and so we need to fulfill the diagnostic criteria for depression to move on for the management of this patient. So the correct answer is D, ask about suicide ideation. We will not admit the patient or start cyclophosphamide, as these are things related to SLE, rheumatological or connective tissue diseases. It's beyond our topic. We will not start medication before diagnosing the patient. So as you remember, the clinical problem solving is start with diagnosis, then determine severity, then management of the patient, and then follow up. We finish from the first step, then move to the second step. If the MCQ is talking about management, they will mention in the question that this patient is already diagnosed with this or that disease and what is the management. Question number 3, 38-year-old male presented with history of belief that the company he works with is stealing his ideas and talking to him through a microchip in his brain for 6 months. He still enjoys going out with his friends. What is the diagnosis? As you can see the answers, you can pause the video and think about it. So this patient presented with frank, delusional, and abnormal bizarre thinking, and this per se is enough to diagnose anyone with schizophrenia. And the duration here is very important, more than 6 months. So this is the diagnostic criteria of schizophrenia. So the answer is B. Why it's not schizoaffective disorder or depression with psychotic feature? Because in the MCQs, there is nothing mentioned about depression or depressed mood or mood disorder in general. Why it is not schizophreniform disorder? Because the duration is more than 6 months. And everyone will have to review the diagnostic criteria of schizophrenia spectrum disorder. And why it's not delusional disorder? Because this is a frank, delusional, abnormal, bizarre thought, which is diagnostic criteria of schizophrenia. There is something called Schneiderian first rank symptoms. Schneiderian from Schneider, who was the scientist who put the first rank symptoms. First rank symptoms are any abnormal thought or behavior or delusional or hallucinational symptoms that are frankly bizarre. Whenever we see any of these symptoms, this is directly schizophrenia. Because sometimes delusions or abnormal thought or hallucination can be something, could be real, and can be something mood congruent, and these are not it's not important to be schizophrenia. It could be something else, or it could be normal reaction to stressful events and so on. The presence of any bizarre symptoms, hallucination, delusion, in absence of organic brain disease is usually regarded as diagnostic for the schizophrenia. What if the same scenario with non-bizarre delusion, as we mentioned, the duration of symptoms, for example, if it is less than 6 months, but more than 1 month, this is schizophreniform disorder. If it is less than 1 month, we will call it acute psychotic disorder. What if the same presentation but associated with mood symptoms, and this mood symptoms mainly of depression for more than 2 weeks? This is usually schizoaffective disorder. In the other scenario, if the patient is start with depression, purely depression, and diagnosed with major depressive disorder for a long period of time, and then developed hallucination or delusional thoughts. Question 4, 30-year-old female presented 6 months postpartum complaining of recurrent thoughts of killing her infant with a knife. She doesn't want to kill her infant, but she keeps getting these thoughts and images. She had removed all sharp objects from house and didn't tell her husband. What is the management here? So of course, in order to know the management, you have to know the diagnosis. Is it fluoxetine, olanzapine, haloperidol, or reassurance? You can pause and think. And now the answer is A, fluoxetine. Why it is fluoxetine? Because this patient is complaining of obsessive compulsive disorder. This is perinatal obsessive compulsive disorder, Why? Because that she has no control over them. It is intruding thoughts with no control over these thoughts of doing something that she does not want to do. And so there is no mood disorder in the scenario, so it is not postpartum depression, and there is no hallucination or delusions in the scenario, so it is not postpartum psychosis or psychotic disorder. And these thoughts are obsessions that the patient is complaining of, and so it is obsessive compulsive disorder with a specifier of becoming after delivery of the patient, of the baby. That's why we call it perinatal OCD. So what if the same scenario, but she hear voices telling her to kill the baby? So this is a postpartum psychosis because she is hearing sounds, hallucinations. It's not obsessions of thoughts that intrude her brain without control. What if the same scenario but associated with low mood? So this is postpartum, either blue or depression, according to the severity and duration. So peripartum onset specifier, postpartum OCD or postpartum depression, postpartum psychosis has the same diagnostic criteria of each. For example, OCD diagnostic criteria is the same, but whenever it comes after delivery of a baby, we call it postpartum OCD. The same thing for postpartum depression, the same diagnostic criteria of MDD, but because it came after postpartum period, so we call it postpartum depression. This is what is called specifier. Question number 5, 30-year-old female complaining of her abnormal looking nose, no history of delusions or hallucination. On examination, she is unremarkable with normal facial feature and non-dysmorphic nose. What is the management? So you have to know the diagnosis first to know the management. The answer is reassurance, CBT with SSRI, CBT with haloperidol, referral to plastic surgery. What do you think? Both? So the answer is B. It's body dysmorphic disorder, which is a mental health condition that disrupts how patients see and feel about their own body and appearance. Pharmacological treatment with SSRI and non-pharmacological treatment with CBT are the effective best evidence for the treatment of body dysmorphic disorder, and you can see the diagnostic criteria here. Question number 6, a 22-year-old lady presented to the emergency department with dyspnea, chest pain. On further questioning, she claimed that she is going to die and something wrong is going to happen. She is medically free and had multiple episodes of such scenario where she was always reassured and discharged. On examination, she has tachypnea and tachycardia with noticeable body shaking, hard to get her attention, and screaming that she is going to die. Investigations were done with negative result. What is the emergency treatment? Flurazepam, diazepam, fluoxetine, or any form of beta blockers. So what do you think? You can pause and come back for the answer. The answer for the question is B. We will give diazepam. And here is very important note why we give diazepam, not SSRI. So this patient is having panic attack, and panic attacks are part of many other mental disorders, especially panic disorder. And panicking is an emergency situation that needs something to calm down the patient, and that's why this is the emergency management with diazepam. But whenever the patient is diagnosed with panic disorder, the diazepam or benzodiazepines or anxiolytics in general are emergency treatment only. But for the long-term management, we need to have SSRI for the patient and psychotherapy, mainly cognitive behavioral therapy. Panic attack is a symptom, is not a disorder. but panic disorder is a disorder. In panic attack, the patient can present with physical and mental presentation. Physical symptoms will include tremor, tachycardia, tachypnea, and so on. Mental disorder like fearful, agitation, confusion, depersonalization, derealization, and so on. Panic attack can be presented with many disorders, physical or mental, like generalized anxiety disorder, panic disorder, agoraphobia, and so on. So the treatment of panic attack and panic disorder: in emergency, we will give anxiolytic medication like diazepam or alprazolam, but for long-term treatment or the treatment of panic disorder as a disorder, we need to have SSRI as a main treatment. And for the diagnostic criteria, you can go back to the handout for more details. Question number 7. A 41-year-old male brought by his wife with history of car accident 2 weeks ago. So put many lines under this 2 weeks back, where his father and sister died and he couldn't save them. He is tearful and refused to drive again and would tell everyone to avoid driving in that street where the accident happened. What is the diagnosis here? So this patient had been through a traumatic event, and this traumatic event was 2 weeks ago, and now he is experiencing the consequences of that traumatic event for 2 weeks only. Is it acute stress disorder, post-traumatic stress disorder, adjustment disorder, an anxiety disorder, or it is something normal reaction that need reassurance? Of course, it is not normal reaction that need reassurance, because there are a lot of diagnostic criteria involved in the stem of the question, and you can go back to the diagnostic criteria of stress disorders in general. Whenever the patient having symptoms that affect his life, affect his functioning in life, causing dysfunction, the avoidance behavior, the fearful, the tearful, sadness, all of these symptoms that the patient presented with is telling us that this patient is having a disorder. This is not a normal reaction. Is it an anxiety? There is nothing regarding to the diagnostic criteria of an anxiety disorder, and an anxiety disorder is a big umbrella with a lot of disorders like generalized anxiety disorder, panic disorder, a specific phobia. So there is nothing called just an anxiety disorder. Is it adjustment disorder? This is the trick here. Adjustment disorder will also start with 2 weeks, yes, but the exaggeration of symptoms will not be as severe as this presentation. And usually adjustment disorder does not occur after a traumatic event, but usually it occurs after an event that is like, for example, somebody who moved from neighborhood to other city, got married or divorced, and such events, but not a traumatic event. So still post-traumatic stress disorder, this is a diagnosis after 1 month. So before 1 month, it is acute stress disorder. And this is the diagnostic criteria. You can go through it here or in the handout. What is usually the treatment of acute stress disorder? Acute stress disorder and post-traumatic disorder are usually treated the same, mainly with SSRI and psychotherapy. Acute stress disorder, usually we can depend more on the psychotherapy, a form called trauma-based psychotherapy approach. Some evidence found that SSRI may help acute stress disorder not to develop post-traumatic stress disorder. What other medication that we can prescribe also for acute stress disorder or post-traumatic disorder? We can give also another medication that will be a symptomatic treatment, for example, help in sleep, appetite, and whatever, but it's not the main treatment. The main treatment is SSRI. It's also, you can go through it. Question: a man works while the place were on fire. 3 weeks ago, he couldn't run until his friend came and saves him. He has multiple burns, report having nightmares, difficulty sleep, and low mood. What is the diagnosis? Is it post-traumatic stress disorder, adjustment disorder with depression, primary insomnia disorder, or is it generalized anxiety disorder? So what do you think? This is post-traumatic stress disorder. This is not 3 weeks. A man works 3 weeks ago. No, this is more than 4 weeks. There is a mistake in the question. It's more than 3 weeks. So you can see here in the note, first of all, the question has a mistake. This is typically as the question was written in the review of Saudi Commission for Health Specialties MCQs. So since it is listed, yes, the closest one was post-traumatic stress disorder. Why it's not adjustment? As we mentioned in the previous question about the traumatic event. Another test: a soldier participated in Hazm Storm 4 months back, presented with flashbacks and nightmares. These symptoms affected his life significantly and started to avoid any related places or persons. What is the best treatment? So this is a post-traumatic stress disorder. What is the treatment for this patient? As we mentioned, SSRI is the main treatment, so A, sertraline is the treatment. Why sertraline? Because SSRI are the main treatment. What is the role of diazepam? So in acute presentation, in emergency, for example, as panic attacks, for sleep abnormalities or insomnia, we can prescribe diazepam as a symptomatic treatment, but not for the main treatment of post-traumatic stress disorder, which is SSRI. Question 8. 58-year-old male, status post-MI, complaining of symptoms and diagnosed by MDD. What is the best antidepressant choice for him? Now, this question is about somebody who have cardiovascular disease and what to choose as antidepressant for them: sertraline, quetiapine, amitriptyline, or methylphenidate. So methylphenidate is CNS stimulant. Usually it's not used for treat depression, but in some patients with palliative or end-of-life treatment of depression, we can use methylphenidate, which is not the case in this MCQ. Amitriptyline, yes, it is antidepressant, but it's not suitable for somebody who have cardiovascular disease because the side effects profile for tricyclic antidepressants in general is high for the cardiac disease. Quetiapine is an antipsychotic, it's not antidepressant, so the first and the best choice is the sertraline. First line of treatment in this patient is SSRI in general, regardless of the sertraline, fluoxetine, whatever. A better choice could be combination of SSRI and CBT. For example, if we have in the options SSRI and the other option is SSRI and CBT, of course we will choose SSRI and CBT. Although SSRI is safest antidepressant in general, but for cardiovascular disease, even among SSRIs, there are better than each other antidepressants. For example, sertraline, fluoxetine is the best. Escitalopram found to be the highest SSRI side effect profile on cardiovascular disease, mainly for the QTC prolongation. So before prescribing any SSRI for a patient who is cardiac patient, we have to do ECG to see his QTC duration. If it is prolonged, it's better not to start SSRI. You can pause the video to see these tables about the QTC effect of antidepressants. We can see here the sertraline, fluoxetine, paroxetine, duloxetine among the safest antidepressant on the QTc efficacy. Bupropion has been studied in cardiac patients. Statistically significant change in blood pressure were observed with no determinantal effect on cardiac conduction or contractility. Vanilla vaccine is the least desirable for use in patients with pre-existing cardiovascular disease, as a statistically significant increase in heart rate and blood pressure have been noticed. These are the top side effects of tricyclic antidepressants on cardiovascular system that will increase hypotension, cardiac conduction, increase heart rate, and it's a pro-arrhythmic effect. Question number 9, 41-year-old known case of overactive bladder on oxybutynin, presented with symptoms of depression and so diagnosed by MDD. What is the right treatment for this patient? So patients who have overactive bladder, irritable bladder on oxybutynin. What is oxybutynin? It is an antispasmodic medication that used with people who have irritable bladder to relax the muscles of the bladder and relieve the symptoms. So we know that this patient having irritable bladder or overactive bladder, and we will start this patient on antidepressant. It's better to give antidepressant that will work on both, on the depressive symptoms and on the bladder. And among the antidepressant categories, we have SSRI, SNRI, TCA, atypical antidepressants. Among all of them, the tricyclic antidepressants have anticholinergic effect that will also help in treatment of overactive bladder. So in the options, we will choose a TCA among them. Amitriptyline is the TCA among the options. Fluoxetine, olanzapine, buspirone are not TCA. So the correct answer is A. TCA in general can be used as treatment for irritable bladder. Even if the patient is not having depression, we can give TCA to treat the irritable bladder, but we have to rule out other interaction with general health of the patient or other medication. The most commonly used TCA for overactive bladder are imipramine and dextribine or amitriptyline. TCA works on bladder as an anticholinergic properties. Question number 10, 32-year-old male, known case of MDD on paroxetine for few months, decided to stop the medication by himself due to sexual side effect and weight gain. He presented to urgent care crying and complaining of irritability, flu-like symptoms, sleep troubles, tingling sensation, and severe nausea. On examination, he has elevated blood pressure and looks anxious. What is the appropriate management for him? So this patient has decided suddenly to stop the paroxetine, which is the SSRI, and all of these symptoms occurred after he suddenly stopped the medication. So what is the diagnosis here? This is SSRI discontinuation syndrome, where the patient will have sudden drop in the serotonin concentration and will have these symptoms. So what is the management here? Do we have to start other SSRI, for example, bupropion, or to restart the same medication, paroxetine, or start fluoxetine, or reassure the patient and discharge? We can say that reassurance and discharge is somehow can be a good choice, as long as we remember that serotonin discontinuation syndrome is not a serious disorder. But the better choice here is to restart paroxetine and then withdraw or taper down the medication gradually. So the best answer here is B. Restart paroxetine and then taper down the medication. These are the symptoms and signs of antidepressant discontinuation syndrome. So SSRI profile, we can see that fluoxetine is the best antidepressant that will not cause discontinuation syndrome because it has the longest half-life. Paroxetine, on the other hand, have the shortest half-life and is the most common SSRI that will cause antidepressant discontinuation syndrome. So the management usually is to restart the same antidepressant and then taper down the medication until the patient is completely off the medication. How to taper down antidepressant? Usually to follow the rule of 25%. So each week reduce the dose by 25% until the patient is off medication, and this will take around 3 weeks. 3 weeks to 1 month. Does TCA cause also discontinuation? Yes, but the TCA discontinuation is more severe than SSRI because the patient will not have only the serotonin withdrawal effect or drop of serotonin only, but also will have the cholinergic rebound also, because the TCA have an anticholinergic effect. So whenever we discontinue the TCA, the cholinergic effect will be higher, and that may cause Parkinson-like symptoms to patients who are on TCA for a long time and they suddenly stop taking the medication. As we mentioned, how to taper down SSRI by the rule of 25% each week, by the rule of 25% dose reduction every 2 weeks. This is the most evidenced, but if we discontinue 25% every week, it will work also, and it is also safe. But the best evidence for tapering down of SSRI is 25% every 2 weeks, and that will take up to 6 weeks of tapering down SSRI. Question number 11. Patient known of schizophrenia need to be started on clozapine. What should be followed from the following? Is it CBC without differential count, CBC with differential count, liver function test, or clozapine blood level? This is a very straightforward question, because we know that clozapine is a second-generation antipsychotic that have a side effects of neutropenia. It will cause drop of neutrophil counts, and that's why we need to check the CBC with differential. If we do CBC without differential, we will have the total number or total amount of WBCs, and that will not help in the follow-up of the side effect of clozapine. We have to see the neutrophil per se. So an uncommon but serious side effect of clozapine is severe neutropenia, defined as absolute neutrophil count less than 500. When starting clozapine, neutrophil is measured every week for 6 months, then every other week for 6 months, then monthly, as long as the patient having normal CBC with differential. And it is the only antipsychotic that is evidence to cause neutropenia. This schedule is very important, showing the most common side effects of the antipsychotics. First generation antipsychotics, major side effects is extrapyramidal side effects, while the typical or second generation antipsychotics side effects is mainly on the metabolic syndrome. This is already, we mentioned this. Question number 12. A 6-year-old boy presented by his parents to the clinic complaining that their child is refusing to go to the school and insisting to return home every time the family leave their house. The child said every time he is going to school feels excess worries and abdominal pain and sometimes headache. The child is still sleeping in his parents' bed. So there are physical and mental symptoms here, mainly of anxiousness and panicking. The child otherwise normally developed with normal social interaction and does not mind going to school with his parents. What is the diagnostic criteria? What do you think about this? Is it a specific phobia? Is it generalized anxiety disorder? And so the correct answer is A, separation anxiety disorder. It's normal social development period. So separation anxiety can be a normal developmental period in kids around 6 months to 3 years. But after 3 years, whenever the child experiences separation anxiety, this is disorder. Most common manifestation or most commonly manifested at school age or kindergarten if the child go to kindergarten before 6 years, because this is the real separation that will happen to the child from their parents. Question 13. A 4-year-old boy present with his parents to the clinic with history of not communicating with his family or show connections. So there is a problem in the communication and connection or emotional connection. In the clinic, he is repeating sounds and busy arranging pens on the desk without response to direct communication or making eye contact. The child is within normal growth measures and motor development. What is the diagnosis? I think this is very clear that this patient is having autistic disorder or autism. The child is physically within normal growth. The child's motor development is normal. No signs or symptoms of neurotic or mood disorder. He lacks social interaction with stereotyped vocal symptoms, and these are the main diagnostic criteria for autism. Question number 14. Old boy reporting recurrent episodes of waking up at night, crying for 1 hour, and return back to sleep, and he doesn't remember anything in the morning. What is the diagnosis? So the trick here is that he does not remember anything when he is awake. So what is the diagnosis? Is it night terror or nightmare? Usually night terror is something frightening, something abnormal, something as we call it parasomnic disorder. It's not dysomnia. It's not a normal process like nightmare. Nightmare is when children have dreams that is frightening them, and when they wake up they remember everything and they will tell what happened. But night terror is something the child may awake while asleep. He looks like awake, open his eyes and communicate with the surrounding, but they are not awake in reality, and when they wake up in the morning they do not remember anything. So this is a night terror, and you can see here the difference between both. You can pause the video and see them. Question 15. A 35-year-old female whose co-worker died from MI. Since then, she started feeling excessive worries of developing MI2 and check her blood pressure regularly with multiple visits to ER complaining of symptoms of MI, where she do a full MI workup that end with normal finding every time, which reassured her for a short period of time, but then became anxious again and preoccupied with developing MI. What is the diagnosis? So the patient is very anxious about a specific disorder, and this is very important for the diagnosis. Just one disorder, which is MI, or let's say cardiovascular disease only, worried and preoccupied with fear of cardiovascular disorders only, not every time present with different complaint with different system, and this is roll out somatization, and it's not convergent because there are no real symptoms, or for example seizure disorder or any neurological disorder that's increased or happened after a stressful event, and this is the diagnostic criteria of convergent disorder. So we rolled out also convergent disorder, and it's not delusional disorder because every time the patient did the investigations, she is reassured, and this period, even if it is short period of reassurance, will rule out delusional disorder because it's not fixed belief, but it is arguable belief. It's not malingering because the MCQ or the question does not provide any malingering behavior. So there is a mistake here. Sorry for that. The answer is C, illness and anxiety disorder. Illness and anxiety disorder, or what's called previously hypochondriasis. And we have explained why it is illness and anxiety disorder. From the name, it is illness and anxiety disorder. That means this patient is preoccupied about one disorder for a long time, just thinking about this disease and need to roll out every time this disease itself, not presenting with different disorder every time. You can see this image also later on. What if the patient has physical signs, for example, seizure, experiencing under stressors? This is convergent disorder. What if the patient has fixate to one illness and always worried from it and try to find its symptoms in their body? This is illness and anxiety disorder. What if the patient has multiple complaints of different body parts and systems? This is what's called, previously called somatization disorder, and now it's called anxiety disorder. It's called now somatization disorder. And what if the patient has arguable belief that a part of his body is disfigured and ashamed of it, and this is body dysmorphic disorder? What if the patient who fabricate an illness in order to have medical care and willing to go through any risky procedure? So this patient having factitious disorder. Factitious disorder is that the patient does not have any symptoms, real symptoms, not complaining of any symptoms, not experiencing any illness, but they fabricate the illness. They lie to the doctors that they have symptoms, and they are willing to go through any procedure, even if it is life-threatening procedure, just to get the attention and be around physicians and so on. But there is no secondary gain from that. They do not want, for example, sick leave or something like that, or money or whatever. So this is factitious disorder. But if the patient have a secondary gain, like we will see in the second point, patient who fabricate an illness in order to get secondary benefit, for example, sick leave or helping other or getting money, whatever, this is malingering disorder. Last point is a person who use other sick persons, for example, their mother, their son or daughter, in order to get attention, and this is what's called Munchausen by proxy. This table, you can go through it after the video. So a female complaining of headache and afraid of having a brain tumor. She had multiple visits to the hospital with normal result and is still concerned. What is the most likely diagnosis? It is an illness, an anxiety disorder, convergent disorder, somatization, or generalized anxiety disorder. What do you think? It's of course illness and anxiety disorder. And why it is not somatic symptom disorder or somatization disorder? Because it's fixed to one disease and not presented every time and then with different symptom or different system. So what is the management of somatic symptom disorder or somatoform disorder in general? All of them is to schedule a regular appointment, establish a strong therapeutic alliance with the patient, acknowledge their symptoms. Do not tell them that you don't have anything, you do not feel anything, and it's all in your head, and like this will make the patient not trustable therapeutic relationship with the doctor. Limit diagnostic testing and referral to subspecialties. Of course, psychotherapy and sometimes SSRI for combining symptoms, because most of people with somatic symptom disorder, they will have also an anxiety or depressive disorder. This is a mnemonic approach for treatment of somatoform disorder, CARE MD approach. Question 16. Patient whose labs show prolactin level to be high. His medication include risperidone for schizophrenia, lisinopril for hypertension, metformin for diabetes, and statin for dyslipidemia. Which of the following can cause increased prolactin level? Is it risperidone, metformin, statin, or lisinopril? And this is direct forward question. All antipsychotic medication will cause increase in prolactin production or prolactin hormone, and that may increase the breast size or cause galactorrhea. Question number 17. Patient with renal impairment and alcohol disorder was previously social drinker. He drinks on daily basis now, and realizing that it affects his life and his duty. What is the first line medication to increase alcohol abstinence? So is it acamprosate, naltrexone, disulfiram, or topiramate? And this is also a straightforward question. Naltrexone is the first line treatment of alcohol addiction. Yes, disulfiram is also a treatment, acamprosate and topiramate, but naltrexone is the first line treatment. As we can see, naltrexone and acamprosate is the first line treatment, but acamprosate is contraindicated in patients with renal failure or renal impairment, and we can see in the MCQ here that the patient is having abnormal renal function. Second line treatment is disulfiram, topiramate, or gabapentin. Question number 18. A 67-year-old female known case of schizophrenia with recent history of increased agitation and auditory hallucination. Haloperidol dose increased from 2.5 to 10 mg. On the ER, she was having muscle rigidity on flexion and extension, heart rate 121, irregular. What is the following investigation is required to establish the diagnosis? This also is a direct forward MCQ. This patient is having malignant neuroleptic malignant syndrome, and the answer is D, which is part of the diagnostic criteria of neuroleptic malignant syndrome. In neuroleptic malignant syndrome, the patient will be presented with hyperthermia, rigidity, altered consciousness, and so on. But in any MCQ, the picture will be hyperthermia, rigidity, and so on. And you need to do creatinine kinase that will be elevated, and that's the diagnosis of neuroleptic malignant syndrome. After initiation or increasing the dose of any antipsychotic disorder, especially first generation antipsychotic, or also known as typical antipsychotic. So this is a test. Middle-aged male patient, known case of schizophrenia, 4 years on medication. He presented with fever and rigidity. What can be given to him to decrease muscle rigidity? So the patient is having antipsychotic medication that caused him muscle rigidity and fever. What do we call muscle rigidity and fever in any patient who is on antipsychotic medication? It's called neuroleptic malignant syndrome. So what is the medication that can be given to such patient to decrease the symptoms of neuroleptic malignant syndrome? To answer the question, we have to know the cause of neuroleptic malignant syndrome. Antipsychotics can cause withdrawal of the patient's dopamine in the CNS. This drop of dopamine can cause neuroleptic malignant syndrome, and so to reverse this effect, we have to give medication that will increase the dopamine. And among the medication in the options here, bromocriptine is the suitable one. So bromocriptine is the right answer. Question 19. 19-year-old female patient with anorexia. Examination shows BMI of 15. How to manage her? So this is a straightforward question about how to manage a patient with anorexia nervosa. Do we refer to psychiatric hospitalization, refer for CBT, and follow up after 2 weeks? Tell the family this is normal behavior for teenage. Start her on bupropion. Of course, bupropion is the worst answer here, because bupropion by itself is an anorexic medication that will decrease the appetite and decrease the weight of patients who are using it. And we have here a patient with anorexia, so we have to avoid bupropion or any anorexic medication. Telling the family that this is a normal behavior for teenagers, this is not correct. The patient have BMI of 15, which is severe level of anorexia nervosa, and for the diagnostic criteria and severity assessment of anorexia nervosa, you can go back to the handout. Do we have to refer this patient to psychiatric hospitalization? There is no enough details telling us how severe it is. Is the patient is bedridden, having confusion or delirium or whatever the status of the patient? And knowing that CBT is the first line treatment in anorexia nervosa, so we will choose B. So as long as the patient is stable, we will start with close monitoring with CBT directed to anorexia nervosa. And if the patient is unstable, yes, we have to admit the patient and start feeding the patient and start the CBT in the hospital. But we have the feeding need to be very cautious not to cause a refeeding syndrome that will lead to an electrolyte imbalance, which is very life-threatening to the patients. So in summary, eating disorder are of two types, anorexia nervosa and bulimia nervosa, and you can go through all of these details in the handout. 19-year-old female complaining of lethargy and almost fainting. That means the status is very severe or unstable. On examination, her BMI is 14, which is an extremely severe state of anorexia nervosa. She was admitted to the hospital and started CBT sessions besides judicious parenteral feeding to compensate her weight, and this is the problem, judicious parenteral feeding. After initiation of feeding, she started feeling difficulty swallowing and breathing associated with nausea and vomiting. Next, she was found confused and developed seizures. How to manage this patient? Now we know that the doctor treating this patient has committed a mistake, which is judicious parenteral feeding to a patient who is already on anorexia, and that will cause refeeding syndrome. And also refeeding syndrome will cause electrolyte imbalance and will cause the same picture that we see here, the seizure, fainting, confusional state, and so on, which is a life-threatening situation. So the right answer is it start different type of psychotherapy, slow down the rate of feeding, or this is a normal reaction to the treatment? The correct answer is B. So this is a patient with anorexia nervosa. It was the right decision to admit her because she is unstable and do investigations and start psychotherapy. Important part of treatment is to start feeding gradually with monitoring or with vigilance monitoring of electrolytes and micronutrients to prevent developing refeeding syndrome. This is a picture of symptoms and signs that will be encountered in refeeding syndrome. Question number 20. A 31-year-old female school teacher married with 3 children, reporting that her husband was insisting on her to see a physician because she has episodes of irritability, anger, low temper, and sometimes looks confused or anxious. These symptoms associated with headaches, abdominal cramps. Upon questioning these complaints, urges before each menses and dramatically subsided once the menses start. What is the first line treatment for her? So this is a very, very obvious depression symptoms related to the menstrual cycle. So what is the diagnosis here? We have premenstrual dysphoric disorder. It's not premenstrual syndrome, because the presentation or the symptoms is severe enough that even the husband is complaining and she become dysfunctional during these symptoms. So it is premenstrual dysphoric disorder, which is more severe form of PMS. And how to treat PMDD is the same like the treatment of depression with SSRI. Actually, as we have mentioned previously, depression can be in any form, can be MDD is the basic with diagnostic criteria of MDD, but whenever the MDD presented in association with other things, which we call specifier, the name of the disorder will be changed, but the treatment is still the same like the MDD. So when the MDD become associated with the menstrual cycle, we will call it premenstrual dysphoric disorder. But when the MDD associated with postpartum state, we will call it postpartum depression, and so on. But the diagnostic criteria is the same and the management is the same. The first line treatment of any depression anytime is SSRI. OCB are effective for treatment of PMS and PMDD also. So this is a confusing option when it comes in MCQs, like what is the treatment? Is it SSRI or OCB? Always, whenever we have depression, the first line of treatment is SSRI. When we have a very few symptoms that's not fulfilling the diagnostic criteria of depression, we can say that the answer is OCB. On the other hand, also, we can augment the treatment of premenstrual dysphoric syndrome. We will start with SSRI, but we can augment also the treatment with OCB also. SSRI can be used continuously or during the luteal phase only in case of PMS or PMDD. There is evidence, level B, for calcium supplementation that it can help also to improve PMS symptoms. CBT may improve PMS and PMDD, and of this is the diagnostic criteria. Question 22. A 43-year-old female housewife presented to the clinic complaining of uncontrollable thoughts. This is very important. Uncontrollable thoughts. Whenever we hear uncontrollable thoughts, the first things come to our mind is obsessions. So she is complaining of uncontrollable thoughts about her house, of being always dirty, whatever the effort of cleaning she does. She believes that these thoughts are not true, so she is aware or incited about it, but cannot help to stop cleaning the house over and over until she got tired. This has definitely afflicted her quality of life and marital relationship. So she is doing the cleaning in order to respond to the thoughts that she has. So this is the meaning of compulsions. So this patient, clearly that she is complaining of OCD. And why we are not saying that she has obsessive compulsive personality disorder? Why it is OCD? Because she is complaining of these thoughts, obsessions, and the compulsions that she has to do in order to feel relief. So this is what we call it ego dystonic, not ego syntonic presentation or type of symptoms. So what is the treatment of OCD? Is it CBT? Is it escitalopram, fluoxetine, or whatever the other choices? We have, as we know, OCD first line treatment is SSRI. In the options, we have two SSRI, escitalopram and fluoxetine. Which one we can use? Is it escitalopram or fluoxetine, and why? Of course, we will choose the SSRI that have a higher dose. Whenever we have the questions, whenever we have the choices for the question, we will start always having the SSRI with the higher dose. For example, if we have fluoxetine with, for example, 50 or 60 milligram, this is the correct answer. If we will have escitalopram with 20 or more milligram, that is the correct answer. In our choices, we had two SSRIs, but both of them are with low doses, and it's mentioned that this is even the target dose. That means we will not increase the dose even more than that, and this is very incorrect, because OCD will always be treated with very high doses of antidepressant. And we have also evidence that even CBT can be alone as first line treatment, and so the correct answer among these options is the CBT. As we can see, recommended first line therapy for OCD is CBT and or SSRI. So CBT alone can be a choice, but if we have CBT or psychotherapy and we have another option which is SSRI with a very high dose, that means this is the correct answer, the SSRI with higher dose. But SSRI with low dose, comparing with CBT, we will choose CBT. In severe cases, SSRI must be started with or without CBT. In severe cases, OCD always require a high doses of SSRI. CBT type used in OCD called exposure and response prevention. The patient will be exposed to things that he has worries about and will be prevented from reaction in order to treat these abnormal thoughts that they have, which is called obsessions. Other modalities include the arguable questioning of what if. For example, if the patient is having fear, for example, of germs and dirtiness around him, we will start the questioning of what if you are in such a situation, what you will do, and then we will argue with the patient about his answers. What if this happened, or what if that happened? What if you do not respond to that? What will happen? Of course, nothing will happen, and so on. Augmenting SSRI therapy with atypical antipsychotic is effective in some patients with OCD who have inadequate response to SSRI therapy. That means if the patient having OCD and we start him on SSRI and reach the maximum dose, and there is not sufficient response to the SSRI, we can even add antipsychotic. OCD patients should be monitored for other mental disorder, because most of OCD patients will have a combining also depression or anxiety. These are the doses or recommended doses of SSRI to treat people with OCD, and these are other type of OCD or OCD related disorders, and its recommended treatment. Question 22. 28-year-old female, obese patient diagnosed with MDD, want to start antidepressant and concerned about weight. Which medication won't increase the patient weight? This is a direct MCQ. What antidepressant that will not increase the weight? Of course, bupropion. Mirtazapine among the highest antidepressant that will cause increase in weight due to it stimulates the appetite due to its side effect as antihistamine. So bupropion may have fewer sexual side effects than SSRI and appear to induce a modest weight loss, but has a higher incidence of insomnia and headache. A worth point to be mentioned also that bupropion can lower the seizure threshold, so people known for seizure disorder, we should avoid giving them bupropion. Paroxetine is associated with the greatest amount of weight gain among all the antidepressants. Fluoxetine has been found the lowest one antidepressant or SSRI among SSRI to increase the weight. Mirtazapine has a slightly faster onset of action other than SSRI and may cause less sleep disturbance, but also may cause more weight gain. Trazodone was found also causing weight gain. We have also to remember that trazodone side effect is priapism. Most of TCA will cause weight gain. You can see here, bupropion is the only antidepressant that will not only not increase the weight, but can even help in weight loss. The rest of antidepressant, all of them, either they are neutral or will increase the weight. Always remember, patients react differently with antidepressants. For example, if evidence says that this medication will cause, for example, weight gain, that means almost all people will have this, but some patients will react differently. So we have to treat every individual patient alone, and we have to follow up for the side effects. Weight change could be secondary to MDD itself as pathophysiology or recovery, not necessarily related to antidepressant side effects. Question 23. 12-year-old boy presented by his mother with complaint of headache during weekdays that resolved on weekends. This is a very important part of the question. These things happen during weekdays and resolve on weekends. That means the symptoms here are due to a trigger. Upon further questioning, he mentioned that the headache is worsened whenever he gets to the school and resolved once went home. So the trigger here is the school. Whenever the boy in the school, he will have the headache. Upon further questioning, he has excessive fear, and excessive fear is a very important cue. Excessive fear of a school environment, but doesn't know why. And this is also an important cue. And he would skip going to school whenever possible. So skipping or avoidance behavior, he is normally developed with no other mental or physical complaint. What is the diagnosis? Is it a school phobia, bullying at school, social anxiety disorder, or generalized or whatever anxiety disorder? So he has a specific thing that he is afraid of and try to avoid it. And whenever he has to face this specific thing that he is afraid of, he will be symptomatic. So this is very clear that this patient is having specific phobia from school. Why it is not social anxiety disorder, that whenever the parent bring the child to school, he will have the symptoms. So why it is not separation anxiety disorder? Separation anxiety disorder, the symptoms will happen every time the child have to be separated from the parents, not only in the school, and this is not mentioned in the questioning. Second thing, it's not social anxiety disorder, because social anxiety disorder In social anxiety disorder, the patient will experience the symptoms whenever he has to stand out of the public and have a direct contact with people. So separation, in this question we have specific phobia, which is due to school. Separation anxiety will has the same symptom whenever separated from the caregiver, not only during the school. Social anxiety will connect the symptoms with social involvement moment only in and out of the school. For example, in social anxiety disorder, the child will go to the school normally, will have no symptoms during the whole day in the school, but whenever the child has to stand and speak in public, will have the problem. Yes, of course, bullying is a big concern for children, but when the child asked about the cause, he said that he does not know why why he has these symptoms every time he goes to the school. So what is the treatment for a specific phobia? It's mainly depend on the psychotherapy and especially on exposure therapy. Do we need pharmacological treatment on a specific phobia disorder, whether it is school, insects, heights, whatever the specific phobia? We can give pharmacological treatment based on other mental disorder that the patient has, for example, an anxiety disorder, depression, whatever. Or during the desensitization or exposure therapy, we can give beta blocker, for example, or something anxiolytic to relieve the tension that the patient has. Question 24. A 32-year-old male came to the clinic asking for help because recently he became afraid of malls and supermarkets, a specific area that he has an anxiety whenever he is available in it, reporting symptoms of intense fear of becoming overwhelmed or unable to escape or get help. These symptoms, however, showed off again when he was in the airport and realized that any large place with a crowd in will trigger these symptoms. A few episodes was severe enough to cause him panicking and withdraw attention of surrounding people. Since then he avoids such places. So this is a very clear scenario that this patient is having agoraphobia, which is a type of specific phobia, or used to be in DSM-4 a type of specific phobia. So yes, the answer is C. Agoraphobia disorder, considered one of specific phobia disorder in DSM-4. Agoraphobia is an anxiety disorder that causes an intense fear of becoming overwhelmed or unable to escape or get help. Almost always will be associated with panic attack. Avoidance and anticipatory fear are the important diagnostic clues. So why it is not social anxiety? Because it is not linked to social interaction or public exposure. It's not post-traumatic stress disorder because no history of traumatic event in the scenario. It's not generalized anxiety disorder because the criteria of JAD is not specific. It's not met. And agoraphobia is a specific fear of a specific places, while generalized anxiety disorder is, by its name, it's generalized and anxious state about everything, or even becoming worried about things that doesn't know or doesn't have a meaning. It is a specific phobia in general, but because the patient specify agoraphobia within choices, it's not the best answer. So it is not specific phobia, but agoraphobia. So the treatment of agoraphobia is mainly based on CBT, but we can also give SSRI whenever the patient is having other disorder like depression or anxiety. For example, imagine somebody living with agoraphobia or a specific phobia for a long time on his life. Of course, most of them will develop an anxiety or depressive disorder. Question 25. 23-year-old female delivered her baby 1 week back and presented for postpartum follow-up as she feels depressed and lethargic. So this is a postpartum patient or woman or mother, and she presents with depression within 1 week after putting her baby. She lost interest to care for herself and forced herself to minimally care for the baby. So this is more intense depressive symptoms. She has insomnia and lost her appetite, prefers to sit alone, and feels guilty for having a baby she doesn't deserve. She never had a manic episodes or hallucinations. You can see here the scenario going to depressive disorder in postpartum period. No traumatic event during pregnancy or delivery, and no suicidal ideation. What is the best treatment here? So this is an MDD in the postpartum specifier, so it is postpartum depression. What is the treatment of depression in postpartum? Of course, SSRI is the first line treatment of MDD, but sometimes we have to even choose within the SSRIs, because this is a postpartum patient who is lactating, breastfeeding the baby, and we need the SSRI that is minimally excreted in the milk. And here the answer is paroxetine A. This woman isn't pregnant but lactating, so we need SSRI suitable for lactation, which is paroxetine and sertraline. But if the patient is pregnant and we need to choose an SSRI, so the best SSRI here for pregnancy is even sertraline, but with fluoxetine, not the paroxetine. There is a new antidepressant prescribed mainly for postpartum depression. It's called brexanolone. It's an FDA approved for postpartum depression, and it works through the GABA receptor, not through the serotonin pathway. You can pause and see this table to differentiate between baby blues and postpartum depression. So question 26, 7-year-old boy presented with his parents to the clinic with referral from his school reporting inattentiveness and very active child who can't tolerate to sit on the chair for the rest of the class or stay in the line with his friends. Parents mentioned that their son is always active and can't learn something from the first time. On examination, he has normal hearing, visual, and IQ. What is the first line treatment? So it is very clear from the scenario that this patient is having ADHD. And the question is, what is the first line treatment for ADHD? Of course, it is any CNS stimulant is the first line, and among all of these CNS stimulants, methylphenidate is the number one. So this is a case of ADHD. Usually ADHD is figured out in school or in kindergarten, not by the parents, because the child or the baby has been growing up in front of the parents or the family, and they will not notice all of a sudden how hyperactive this baby is, and not like the other people who will see the child for the first time, especially at school. So the first line treatment is CNS stimulants, and on top of them is methylphenidate. Other CNS stimulants will include dextroamphetamine or mixed amphetamine salts. All of these three are the first line treatment, but among them, methylphenidate is the number one. The second line treatment is atomoxetine, guaifenesin, or clonidine. can we give an ADHD patient an SSRI or antidepressants in general? Yes, whenever the patient who have ADHD have depression also. So, important note, medication should be offered as first-line treatment for ADHD in children 6 years and older, but psychosocial intervention should be the first-line treatment for ADHD in preschool children. This is a very tricky question that will come in MCQs. Whenever the patient diagnosed with ADHD, if the boy, or because boys are more than girls, if the boy will have ADHD, his age is more than 6 years, the first line treatment is pharmacological treatment with CNS stimulant. But if the child with ADHD age less than 6 years or 5 years and below, the first line treatment will be psychosocial intervention, not pharmacological treatment. Third point is stimulant medication are recommended as the most effective therapy for reducing ADHD symptoms. There is no evidence supporting screening general population for ADHD. Q-tip: repeatedly questions about investigations needed to diagnose ADHD. Whenever you have an MCQ about investigation to diagnose ADHD, the correct answer is that there is no single test to diagnose ADHD. Question 27. A wife complains that her husband has no friends and thinks that he is smartest one, and also he is the center of the universe. He believes that he deserves better place for himself, and one time he will show everyone how great he is. He never showed appreciation to his wife, and she mentioned that this is his personality since they got married many years ago. No history of mood or psychotic symptoms. This is a very clear scenario for grandiosity or narcissistic personality disorder, and this is the answer: narcissistic personality disorder. And here we have to talk about personality disorders in general. So all personality disorder have some cues to pick them up, that always mentioned in the question, that this is his behavior or this is his normal personality since long time or since his childhood. He is always grandiose or narcissistic, or he is always violent, for example in antisocial personality, or he is always alone and preferring sitting alone, not interacting with others, and so on, in the avoidant personality disorder. The second important thing in personality disorder, all of them, is that the patient is not complaining about these symptoms. For example, a patient who is schizoid, who lives alone, who likes to work alone, and he feels very eased in jobs that is in, for example, not customer service or not involving with other employee or colleagues. This is schizoid personality disorder, who is feeling happy like that, and he's not complaining that he wants to be sociable but he cannot, and that caused him depressed and so on. And that's what we call it egocentric personality. As we have seen in the previous OCD, for example, a patient who like to arrange things and spend a lot of time cleaning the house, for example, for hours, which is something abnormal, but he feels happy doing that and not complaining about that, and he does not see that this is an abnormality. So this is OCBD, obsession compulsion disorder, personality disorder, not OCD, which is disorder where the patient will be complaining that he is doing something abnormal and it gets him dysfunctional and he wants to be treated. So the treatment in general for all personality disorder is a psychotherapy. There is no pharmacological treatment. And on top of all the psychotherapy for all personality disorder, dialectical psychotherapy is the number one treatment. This is a scenario just to understand how OCPD presented. A 52-year-old man is sent to see a psychiatrist after he is disciplined at his job because he consistently turns in his assignments late. He insists that he is not about to turn in anything until it is perfect. Unlike all of my colleagues, he has few friends because he annoys them with his demands for precise timelines and because of his lack of emotional warmth. This is very common among all of the cluster A and cluster B personality disorder. Most of them will be emotionally lacking emotional warmth. This has been a lifelong pattern, so this is the other cue, lifelong pattern. All personality disorder, it is lifelong pattern. They are always like this since long time or since childhood for the patient. Though he refuses to believe the problems have anything to do with his personal behavior. Alright? A patient who is shy, doesn't have relationships and friendship with people, but get flattered when praised by an authority. What is the type of personality disorder here? So this patient is avoidant personality disorder. Also, this is just a scenario to understand the schizoid personality disorder. And you can pause the video and have a look at it. So whenever it's repeated in any MCQ, you can figure it out. Question 28. A female known case of paranoid schizophrenia on risperidone came to ER with her sister after taking diphenhydramine for allergic reaction, complained of visual hallucination and being irritable all the time. Her sister told you since 1 week ago she is having dry eye, cannot urinate, and with constipation. So the patient is schizophrenic on antipsychotic, a first generation antipsychotic, and took also diphenhydramine. So a combination of risperidone or antipsychotic with diphenhydramine has caused something here, which is a very common side effects of both of these medications, which is the anticholinergic side effects of both of them that will cause dry eye, constipation, urinary abnormal urination, she cannot urinate, and these are all anticholinergic side effects. So what is the diagnosis here? It is anticholinergic delirium. Even without diphenhydramine, risperidone or first generation antipsychotic can cause potential anticholinergic side effects. First generation antipsychotics and first generation antihistamines like diphenhydramine among the highest medication with anticholinergic side effects, and is severe enough. If it's severe enough, can cause delirium. Treatment may include physiostigmine, which is anticholinergic antidote, and supportive care, for example, sedatives and anticonvulsants, and so on. So this is the anticholinergic toxicity. And another example is that 28-year-old female with more than 3 years of low mood along most of the days, increasing with menses. It's associated with fatigue, hypersomnia, decreased eating. She denies loss of interest or psychomotor changes. Symptoms had affected her work. What is the diagnosis? So, is this a premenstrual dysphoric syndrome or persistent depressive disorder? We can agree that this patient is having depressive symptoms. In general, it is a depressive symptoms, so she has an MDD. But what are the specifier here? These symptoms is continuous with her for 3 years. Yes, it has relation to the menses or menstrual cycle, but it does not subside completely once she is not having a period. It's continuous. It's getting worse with menses, but it is continuous even without menses. That means the menses is not the cause or specifier here, and these symptoms is continuous with her for more than 3 years, and this is the diagnostic criteria of the persistent depressive disorder. The point of duration and limited positive depressive symptoms has changed the diagnosis from MDD to BDD. Yes, it increased with menses, but does not relieve after menses started or being depressed symptom-free in between of the menses. So the treatment is like MDD, as we mentioned previously. Treatment of depression is the same like the treatment of depression in any specifier, unless the patient is having some special situation, for example, like lactating or pregnancy or elderly, or another interaction with other medication that the patient is already on, and so on. For example, a patient who is having seizure, we will not give bupropion. Patient who are at high risk of developing priapism, we will not give trazodone. A patient who is afraid that he does not want to gain weight, so we will not give mirtazapine, for example, and so on. Question 30. A male patient was shouting and refusing the nurse to take vitals for him. When the doctor came, the patient took the gloves box and threatened the doctor, saying he will kill him. What the doctor should do in this situation? This is a very straightforward scenario, and the answer could be whether to give lorazepam injection, restrain the patient, try to explain the situation, or shout at him and threaten him as well. So do you call security, or do you argue with someone who will kill you, or do you order medication for somebody who is out of his mind? So I think that the answer is clearly to call the security, because this is a threatening situation for the whole staff. Okay. Question 31. A patient having low mood and loss of interest in which his doctor prescribed a medication. So the patient is having depression and the doctor has given him a medication. Presented with history of dryness of his eyes and blurry vision, with history of urinary retention. And all of these symptoms is symptoms of side effect of the antidepressant in form of anticholinergic side effects. Which of these medication is most likely causing these symptoms? What among the choices is the antidepressant with the highest side effects, especially on the anticholinergic side effects? Of course, the amitriptyline or the TCA in general. TCA in general have the highest side effects among all the antidepressants in form of anticholinergic or antihistaminic or adrenergic side effects. We can see the side effects profile of each TCA and comparison with the specific specific side effects profile as serotonergic or anticholinergic or histaminic or whatever. Question 32. You decided to treat a severely depressed patient with fluoxetine. The response was dramatic, and on follow-up, the patient reported that he feels great. This is very obvious. Somebody who is depressed and given antidepressant, he felt great. Not just happy or normal, but great. That means he is experiencing some form of mania. He has got a lot of energy. In fact, he hasn't slept for 2 days. He just bought a new car despite losing his job. All of these indicating that this patient is in a form of manic episode. You suspect an acute mania. Sure. Which of the following is the best choice of medication to control these symptoms? This is a very important question. So every time we have to treat depression, we have to rule out that this patient is not having manic episodes at all his past life. But sometimes bipolar disorder presented with the first episode of depression and never experienced manic before, and so we will not be blamed to treat them as depression. So once we prescribe antidepressant for them, this will stimulate the manic episodes and they will develop a frank diagnostic criteria of bipolar disorder. So we know that the treatment of depression. What is the treatment of bipolar disorder or manic episodes? We know that mood stabilizers, mainly lithium, and other anti-epileptic medication or drugs like carbamazepine, valproic acid, is the first line treatment and the best treatment for stabilizing the mood of patient with bipolar. But in form of emergency situation, the first line treatment to stabilize patient who is in a life-threatening situation of mania is the antipsychotic medication, not the mood stabilizer. Until the patient is stabilized and he or she got out of this manic attack, then we will prescribe mood stabilizer for the rest of his life to prevent the patient to get into another episode of mania. So the answer is A. Anti-epileptic drugs and lithium are the mood stabilizers that can be used to maintain normal mood after an acute manic attack subsided. But to control acute attack, the best medication is antipsychotics. And among those antipsychotics, aripiprazole, olanzapine, and risperidone is the top of them. And to treat the chronic phase of mania, we will prescribe lithium or anti-epileptic drugs. This is how to differentiate between mania and hypomania. You can pause the video and read it, or go back to the handout for more details. So, which of the following antihypertensive drugs should not be used in patients with lithium in order to prevent lithium toxicity? Is it clonidine, beta blockers, calcium channel blockers, or diuretics? This is a very basic and straightforward question. Which of these medications will increase lithium toxicity? Of course, it is diuretics, because diuretics will increase sodium loss in urine and increase lithium retention, and so increase the dose of the lithium in the half-life in the body and cause more toxicity. So just to remember the side effect of lithium, it's abbreviated in LITH, as you can see. So a 31-year-old male with mood disorder on 30 mg of haloperidol and 1000 mg of lithium is brought to the hospital emergency room with history of acute onset of fever, excessive sweating, confusion, rigidity of limbs, and decreased communication for a day. Examination reveals that tachycardia and labile blood pressure, and investigation revealed increased creatinine kinase enzyme level and leukocytosis. He is likely to develop what? Lithium toxicity, tardive dyskinesia, neuroleptic malignant syndrome, hypertensive encephalopathy. This is a very straightforward MCQ, and we have seen it before. Whenever the patient is on antipsychotic and developed hyperthermia and rigidity, and the creatinine kinase enzyme is high, this is directly a diagnosis of a neuroleptic malignant syndrome. So the lithium here within the question is just a tricky point to see whether you will choose a lithium toxicity or neuroleptic malignant syndrome. So the answer is neuroleptic malignant syndrome. Question 33. A 41-year-old male brought by his wife due to excessive worries about his parents' health. He goes to his appointments 1 hour early, check his bank 3 times a week regularly, As you can see, he has worries about a lot of things in his life, not just one thing, and he always go 1 hour earlier than his any appointment. So worrying about a lot of things in life is just can get us to the point that this patient have generalized anxiety disorder. These symptoms are affecting his sleep, work, life, relationship to his wife, etc. What is the best management? What is the best management for a generalized anxiety disorder? Of course, it is SSRI, whatever the SSRI. How about the buspirone? Buspirone is an anxiolytic medication, but it is not. It's never been a first-line treatment for any mental disorder. It is always an augmentary medication to other anxiolytics or to other antidepressants. So the treatment here is escitalopram, as the SSRI is the first line for almost all anxiety and mood disorder. And go through these evidence-based treatment points in your ease. Just pause the video and read it. This one too. Patient 34, major depressive disorder patient, started on SSRI. After 1 week, came to the clinic complaining of no improvement. The doctor should tell him that it takes how many period of time to show response. So the patient came after 1 week saying that there is no effect. The trick here that when should we assess the therapeutic efficacy of the SSRI? As we have mentioned before, 4 to 6 weeks, let's say 1 month, around 1 month, minus plus minus 1 to 2 weeks is the right time to assess for efficacy of the SSRI. So when we are prescribing SSRI for any patient, we will tell or educate the patient excessively about the side effects and efficacy of this medication, and we will follow up the patient after 1 to 2 weeks for reviewing of side effects and tolerability of the medication, not for the therapeutic assessment. Therapeutic assessment, we will follow again the patient after 4 to 6 weeks to see whether the medication is effective or need to be switched or increased or decreased the dose in case of sexual dysfunction, or stop the medication and start the other one. This is what we mentioned earlier. So a patient on paroxetine 20 mg, after 2 weeks he reported mild improvement. What is the right action? 2 weeks. So we mentioned earlier that in order to assess the efficacy of the medication, we need 4 to 6 weeks. This patient saying that he has mild improvement. So what is the action? Is to continue the same until 4 to 6 weeks. We will see what is the efficacy then. If it's mild improvement, we can increase the dose or continue the same. If there is no improvement, we have to switch the medication from the same class or augment with other medication. Okay, you can go through this slide. Just pause and read it. Another question, a 28-year-old female patient, known case of depression on fluoxetine, and she got pregnant. What is the best management? Here we have to remember that only 2 antidepressants are safe during pregnancy, fluoxetine and sertraline. And this patient is already on fluoxetine and she got pregnant. What should we do to manage her? Of course, we have to continue on the same medication, fluoxetine. Unless the patient is on, for example, paroxetine, we have to switch her from paroxetine to fluoxetine or sertraline. Can go through this reading. Just pause and read. 35, 33-year-old male smoker, known case of epilepsy disorder on medication, wants to quit smoking. What medication can help him quitting smoking? Is it bupropion, pernicillin, nicotine patch, or SNRI? Now we know that this patient is known case of epileptic disorder, and we know that bupropion can decrease the threshold for seizures, and that will exaggerate his epilepsy, and so we have to avoid it. The other thing is that varenicline, what's also called Chambix, it also has a label to be better to be avoided in people who have mental or neurological disorder, especially seizure disorder. So it is better to be avoided also. So the nicotine patch is the suitable one in the treatment. SNRI, there are no any evidence suggesting that SNRI or SSRI other than bupropion can be used in the treatment of smoking cessation. And you can go through this, just pause and read. Pregnant smoker wants to quit smoking but fails in doing so by CBT. Ask about the best medication for smoking cessation during pregnancy. Almost all medications of smoking cessations are contraindicated during pregnancy, except the nicotine replacement, which is the evidence have shown that the harm of nicotine replacement is lower than the harm of smoking itself, so we can use the nicotine replacement during pregnancy. And you can go through this also reading, just pause and read. Question 36. A 68-year-old man present to the clinic 2 weeks after the unexpected death of his wife. So there is a traumatic event here. He is tearful during the interview and describes feeling of sadness and yearning for his lost wife. So this feeling or these depressive symptoms could be normal due to the event that he was going through. He has difficulty sleeping and decreased appetite. He is also describing feeling lonely, but finds himself withdrawing from others. He feels drawn to things that remind him of his wife and has persistent thoughts and memories of her. Which of the following is the most likely diagnosis? Now, these sadness or depressive symptoms could be normal in his situation of grieving that his wife was died, and the duration was only 2 weeks. So is it acute grief? Is it complicated grief? Is it major depressive disorder? What do you think? You can think about it, pause, and go back for the answer. So the answer is acute grief. Why it is acute grief? Because yes, it is severe symptoms, but without the meeting the major depressive diagnostic criteria, and there is an event, a major event that happened to him causing these symptoms for the short period of time of 2 weeks or less than 2 weeks, and that's a grieving manifestation. But if this grieving more for a more prolonged period, that will be called complicated grief. So a person, let's see this case, a person whose friend died in a car accident while he was riding with him. This person is very sad because his friend has died for what happened to his friend. He was very sad. How to rule out that he is not depressed? By checking the list of the diagnostic criteria of major depression. If this patient met the whole criteria, then this is depression, but not just because he is sad or wishing to be died. We can diagnose depression, but we have to fulfill the whole criteria of depression at any point of time in grieving period. So the patient wishes that he was dead with him. do we consider this as a suicidal ideation or not? We have to differentiate within grief the suicidal thoughts from non-suicidal thoughts. If somebody has a beloved one who is dead and he wishes that he is dead with him, this is a normal reaction because this patient is missing that person. We can differentiate that by saying, can you imagine yourself living without that person? For example, how do you imagine yourself after 2-3 years? If he can imagine himself living normally without that person, and it's a matter of time that he will overcome this feeling, that's not suicidal ideation. But if he said, no, my life ends here and I don't want to live anymore and I will commit suicide and so on, and he cannot imagine himself living without them even after 2, 3, 4 years, that should be considered as suicidal ideation. So he came to the clinic complaining of insomnia due to dreams of the accidents that frightened him and can't stop the thoughts about their accident, with flashes all of the time about how scary it was. And he avoided going to the place of the accident or meet the family of his friend because of that it caused him panicking and experiencing the accident emotions again. He relived the same accident every time he has something that reminds him with the accident. So all of these verbal written text is a diagnostic criteria of post-traumatic stress disorder, and that will change the differential diagnosis here from a normal grief or acute grief or complicated grief or whatever grief to a post-traumatic stress disorder, because he has dreams of the accident, he has flashbacks, he has thoughts that he has no control over them about the accident. He avoids places that remind him of this accident, or places or persons who remind him of this of the accident, and he relived the experience every time something reminds him of that accident. So this is the whole criteria or diagnostic criteria of post-traumatic stress disorder. You have to be aware about it. So whenever you have MCQ or a question, start with a scenario of a grief. Don't be misled by that, and figure out the depressive or post-traumatic stress disorder cues from the scenario. He sometimes sees his friend standing in the room, smiling and telling him that it's not his fault and everything is fine. So do we consider this as hallucination or not? As we mentioned earlier, that hallucination or delusion or whatever the psychotic feature, if it is mood congruent or it goes with the picture of the scenario and the patient is incited, it will not consider as psychotic disorder. Somebody, let's imagine somebody, a mom, her child was dead in a car accident, for example, and every time she sits on a eating table, she sees her child sitting in front of her, talking to her, and she tried to reach to him, and then he disappeared, and she is aware that this is not true. When you ask her that, do you think that your child really was there? She said, no, I know that all of this was a dream like, or it's not reality, but because I'm very sad, I miss him so much that I sees him everywhere I look. So this is a mood congruent hallucination that goes with her feeling, and she is fully incited about it. So this is not considered to be hallucinogenic thoughts, hallucinogenic perception, and this is normal reaction or normal grief reaction. So on the other hand, what is the complicated grief? It is a dysfunctional behavior that prolonged longer than 6 months. A lady with recent death of her husband 6 weeks ago, crying and blaming herself. She's been seeing him and hearing his voice What is the diagnosis? Is it acute grief, depression, brief psychotic disorder, post-traumatic stress disorder? What do you think is the answer? Of course, it is an acute grief. It's not depression because there is no enough diagnostic criteria involved in the scenario. It's not also PTSD because of the same reason. And it is not brief psychotic disorder. Although, if you see it from another angle, the patient is having hallucinogenic perception, but as we have said before, it is part of the grief reaction because it is mood congruent and the patient is incited that he or she sees or hear the deceased one because they miss them so much and they want to be with them. You can pause and read these details. The patient came after her father died 1 month back, tearful and feeling guilty. How to manage her? So, in general, a patient on acute grief, how to manage an acute grief? Provide support and reassurance. Start on antidepressant. Refer her for psychiatric evaluation or for emergency admission. So there is no reason for emergency admission as the patient is not psychotic, outraged, psychotic features, or manic or suicidal. Besides, the patient is not having a major mental disorder that need to be referred for psychiatric evaluation. And there is no enough details in the question to diagnose depression to start on antidepressants. And as we all know that the management of grief in general is provide support and reassurance with close follow-up and rule out psychosis or depression. Okay, question 37. Patient known for depression. His mom has depression and osteoporosis. His dad has cardiovascular disease and he is asking what medical condition can be associated with depression. This is a question about depression association with other chronic disease, and the answer is you can pause, read the full answers, and then back for the correct answer, which is the cardiovascular disease. You can pause and read the detailed answer. Okay. Depression is a risk factor for chronic disease. A large body of evidence suggests that depression is associated with increased risk of many chronic disease, including hypertension, diabetes, and particularly coronary heart disease. Question 38. Patient recently moved to live in another city. He came complaining of low mood. You can see here that the patient has done something in his life, a major change. He moved to live in another city, and this should trigger something in your mind. He came complaining of low mood and loss of interest with no friends. So something that looks like depression, but not enough to diagnose the patient as major depressive disorder. He feels overwhelmed and can't work properly, so there is a dysfunction and affected his family relationship to some extent. What is the diagnosis? There is a major change that happened in his life, causing him distress and depression-like symptoms and social dysfunction for a period of time, a specific period of time. So this is all a diagnostic criteria for what of the options below. Yes, it is adjustment disorder. This is just to differentiate between acute stress disorder and adjustment disorder. The trick in adjustment disorder is that the sign and symptoms or the presentation should be started within 3 months of the incident that it happens, and usually in adjustment disorder the event is a life change, a major life change, but not a traumatic event like in acute stress disorder. You can pause and read even this one. because adjustment disorder is usually treated with psychotherapy, not medication, not pharmacotherapy, unless the patient is panicking or cannot cope with the situation, feeling always anxious, unable to sleep or eat properly, and unable to work or be functioning well in the community. So many psychiatrists will prescribe benzodiazepine for a short period of time and with psychotherapy. Unless the patient is having also depression or anxiety, that will indicate prescribing SSRI. Question 39. 45-year-old female complains of depressed mood for few months. Depression symptoms associated with severe hot flashes, night sweating, and sleep disturbances. What is the most appropriate treatment? So this patient is having perimenopause with dysphoric symptoms, and the evidence suggests which of the following that can help the patient in treating the dysphoric symptoms associated with the perimenopause. I will give you time to answer the question. So the answer is estrogen. Estrogen therapy improves mood and dysphoria, possibly by affecting the metabolism of serotonin in the central nervous system. And you can pause and read the rest of the explanation. Other references has both the SSRI as a first line treatment in the perimenopausal symptoms, especially dysphoric symptoms, or even the adrenergic system symptoms, like the autonomic nervous system of sweating, night sweating, irritability, and so on. Question number 40. A young man not on any medication or known for any disorder presented by his friend to ER with agitation, dilated pupil. What substance he has been using? This is a very tricky question, because in substance abuse we have some categories. Some of these categories are CNS stimulants and the others are CNS depressants, where we have mix of toxiderms. Toxiderms are the syndromes that is associated with using of a substance. The toxiderms of substance use or intoxication of a substance is the opposite of that presentation when the patient is presented with withdrawal symptoms. For example, if CNS stimulants can cause the patient to be agitated, the withdrawal symptoms of CNS stimulants will be lethargic or sleepiness. So this patient is a young patient presented with agitation, dilated pupil. These are the only two things have been mentioned. Anyone who is agitated will be presented as dilated pupil also, but dilated pupil and pinpoint pupil is always mentioned with any opioid substance abuse. Heroin, morphine, whatever the codeine, other opioid, all of them are called opioid. When they are intoxicated or overdosed, they present with pinpoint pupil. That means small pupil. But when they presented as withdrawal from the opioid, they were presented by dilated pupils. And so this is dilated pupil, that means there is a withdrawal, and then the correct answer is D, heroin withdrawal. You can pause and see the details, and you can go back to the handout where there are a lot of details about the sinus symptoms, or what they call it toxiderms, for the intoxication and withdrawal toxiderms of each category of drug abuse. Question 41. Patient came with history of pounding heartbeat and dyspnea. He was then diagnosed by an anxiety disorder What is the most appropriate therapy? Is it cognitive behavioral therapy, interpersonal therapy, psychodynamic therapy, or family therapy? All types of all mental disorders, whenever we have types of psychotherapy, the most evidenced and studied psychotherapy module is the cognitive behavioral therapy, and it should be the first line of choices, or the first option to be chosen, unless we have a specific diagnosis. For example, any personality disorder, we will choose dialectical psychotherapy. If we have OCD, we will choose the exposure and response prevention psychotherapy. If we have a specific phobia, we will choose desensitization or exposure or gradual exposure therapy, and so on. Also, you can pause and read the details. Now, question 42. A 26-year-old female, medically free, reported extreme fear from cats, that the fear is unjustifiable and can't imagine herself with a cat in a closed room or closed place. She avoided any place where she could find cats in it and stopped visiting her grandmother because she has cats in her house. What is the first line treatment for her? So what do you think the diagnosis is? A specific phobia from cats. And what is the first line treatment of any specific phobia? We have mentioned this before, that psychotherapy is the first line of therapy in specific phobia disorder. And among all psychotherapy, we can choose CBT, unless within the options, not CBT, the exposure therapy and CBT, we will choose exposure therapy over CBT, as exposure therapy, by the way, is part of the CBT itself. But if there is only CBT and other options like here in this MCQ, antidepressant, group therapy, anxiolytics, we will choose CBT. You can pause and read the details. Question 43. Fatima is a 32-year-old female, medically free, referred to the family medicine clinic by her psychologist, who reported that Fatima suffers from depression episodes, where they found lately by her psychologist she is complaining of symptoms. They found lately, by the help of symptoms recording diary, that it has an annual cycle peaked in winter season. So her depressive symptoms is exaggerated or increased by winter season, which is something seasonal. She found that annually during winter season, she has a lot of sick leaves and feeling lethargic and sleepy all the time and not enjoying any of her usual activities. What is the first line treatment for her? So what do you think this patient is having? Seasonal affective disorder. It is an MDD with a specifier of a specific season, which is winter. So she has seasonal affective disorder. And as we have mentioned before, that MDD or depression, whenever the time it is, or whatever the specifier is, the first line of treatment is SSRI. But in seasonal affective disorder, there is a trick. Bright light therapy or antidepressant, which one is the first line of treatment? And there is a conflict between references here. So, as we have mentioned, that SSRI is the first line of treatment of any depression, anytime, and most references are saying that. But some references that put the light therapy as the first line. This is the NIH. The treatment of SAD or seasonal affective disorder is similar to that of other forms of affective disorder. That means with SSRI. Except that bright light therapy is recommended as first line option, and NIH mentioning that bright light therapy is the first line option. NHS, a nice guideline, recommends that seasonal affective disorder should be treated in the same way of other type of depression. That means SSRI as the first line of treatment. The treatment could be including also CBT and other psychotherapy. The American Academy of Family Physicians said that light therapy, dawn stimulation, and cognitive behavioral therapy are effective treatment. It is effective, but what is the first line treatment? SSRI may play a role in the treatment of seasonal affective disorder. It also mentioned that vitamin D and bupropion can be used also to prevent the seasonal affective disorder. If the patient knows that every time in winter they will develop affective disorder, before winter they can start bupropion or vitamin D to prevent the recurrence of the seasonal affective disorder. So my personal conclusion is that SSRI has been mentioned a lot as the first line treatment of seasonal affective disorder. Bright light therapy has been mentioned as solo treatment only in mild cases, in one reference only. Most references mention that the best treatment is combination of both SSRI and bright light therapy, and also beside combination with CBT. AFB and NICE guideline refer to SAT treatment as exactly how MDD treated, which is as antidepressant with SSRI. Diagnostic criteria of seasonal affective disorder is that the same like MDD, but with a specifier of the seasonal recurrence. You can always go back to the handout for more details, because in this lecture or this presentation we have only read the MCQs, trying to answer it together and with more explanations of the answers. I hope you like the presentation.